every one of you a warm welcome to this 6-day National FDP online on MedTech challenges and opportunities under Make in India framework. So today in this session, we are privileged to have with us Dr. Debopriyo Mondal, who is going to inspire us with his insightful thoughts on artificial intelligence in medicine and cardiology. Dr. Debopriyo Mondal is a well-known interventional cardiologist practicing in Medica Super Speciality Hospital under Manipal Hospitals, Kolkata, India. He has strong academic background right from his school days. He has been awarded with multiple medals and honors during his medical curriculum. He has completed DM cardiology training from C. Chitra Thirunal Institute of Science and Technology, Trivandrum, an institute of national importance, which is internationally acclaimed for quality training in this field. He has completed MD in medicine from PGIMER, RML Hospital, New Delhi, and MBBS from Medical College, Kolkata, during which he was a gold medalist and honors awardee in various subjects. His area of expertise includes complex coronary interventions, cardiac implantable electronic devices, including conduction system pacing, electrophysiology study of arrhythmia, and radiofrequency ablation. Apart from all this, Dr. Mondal has 8 original article publications in many renowned journals and has penned almost 5 book chapters. Previously, he was working as assistant professor at AIIMS Rishikesh before joining Medica Institute. He has over 5 years of experience with most recent knowledge and current practice as per national and international guidelines. He is very keen to deliver the newest technologies without compromising safety and is always active with eagerness to serve the needy. So we are going to have a wonderful 1 hour session ahead of Mr. Debopriyo Mondal, after which we are going to have a 5-minute question answer round. So requesting Dr. Debopriyo Mondal to take over the session. Thank you, sir.
Good evening. Thank you for the kind introduction, Dr. Sumedha. It's been really nice for this session where I would like to convey some parts, probably which I feel will be of importance in terms of not only medical science, but then since it's a forum where the basic background is from the engineering aspect, we'll see how cardiology, artificial intelligence can help us in a lot many ways than we can even think of. And secondly, how people from the engineering streams can take up certain aspects to build up and to help us much more. So I'll share my slides and we'll go through one by one. I'll try to simplify as much as possible so that the complex cardiac aspects are being simplified to the audience, because what I understand is even if I'm told to do the arithmetic part or the maths part of it, I won't understand. Similarly, if I talk in terms of complete cardiology, it will be difficult to understand. So I'll keep my presentation like a layman's perspective. I won't discuss about the artificial intelligence in core, which you are all aware of or much more knowledgeable than me. So let's start the presentation and we'll see at the end of it how we can learn and do better. So are my slides visible?
Yes, sir.
Okay. So good evening, everyone. Again, I'll be talking about the artificial intelligence in cardiology and how it is going to revolutionize the cardiovascular care. I am Dr. Debopriyo Mondal and I am a consultant interventional cardiologist. My background is basically from medical college, MBBS. Subsequently, I moved on to Delhi for my MD medicine from Ram Manohar Lohia Hospital, which is currently known as ABVIMS. Subsequently, I did my DM cardiology from Sri Chitra Tirunal Institute, which is an institute of national importance. And for a short period of time, I was with AIMS Rishikesh as an assistant professor. And subsequently, I have joined Medica, and currently, which is known as Manipal Hospital EM Bypass. I'm also a teaching faculty in the DRNB cardiology training program, which is accustomed to the New Delhi board. So, what are the overviews? What is artificial intelligence? The subfields, machine learning, deep learning, the neural networks, and the importance in healthcare. I do not have any disclosures. I do not have anything to discuss regarding the sponsorships also. So why we have chosen cardiology? Because we all know that the global cardiovascular disease burden is increasing day by day. It is more common than a cancer. Every 5 minutes, we have at least 3 cardiac deaths. The need for early detection and precision medicine is increasing day by day as we go on from precision medicine and data-rich specialty. Like we see ECG, echocardiography, imaging, wearables like the smartwatch, what we have these days. These are all capturing data. So now, as in simple terms, we have a lot of data which we think has to be precisely molded and packaged to make it more accessible, to make it more presentable, and to make it more usable to the general population. So evolution of AI in medicine from rule-based systems to deep neural networks, timeline of milestones in artificial intelligence has come across, I think, probably a long way from utilizing the ECG machinery, which we have these days in various ECG machines, the automated diagnosis which comes up in the ECG tracing paper, as you must have noted. And subsequently, AI is coming a lot in cardiovascular medicine in the interventional perspective also. Since I am an interventional cardiologist, who is an interventional cardiologist? Cardiologist who implants pacemaker, who does angioplasties, who does cardiac devices. We are known as the interventional cardiology people. So AI has actually come a long way to help us in our medicine also. So we have 3 different kinds of learning. We have something called as the supervised learning, which we can actually implement in the ECG classification. We have the unsupervised learning in patient clustering and the reinforcement learning, which is called as therapy optimization. So the way we have learned our ECGs during our training is something which we can say as supervised learning. What is an unsupervised learning? When we have or we see a lot of reports, even though they may not be supervised, we keep on accumulating the data over a period of time and we develop something called as pattern recognition, which is called unsupervised learning. And then we go into reinforcement learning to optimize the therapy. That is the final form of learning. So AI in ECG. So what is pattern recognition? So if I ask an MBBS graduate by showing an ECG, what is this? Probably that student, by seeing the patterns, will recognize that this is a heart attack ECG. He might not be able to decipher the actual graphs, the actual mechanism, or probably the actual diagnosis, but by seeing the pattern, he might be able to tell us what is the diagnosis. So AI, by learning the various patterns in the ECG, can actually help us in making a diagnosis. So this is something called as deep learning. Deep learning is utilizing a lot of data and creating a neural network out of it to create or to give a positive response. How will it help? It will help in the early detection of arrhythmias and structural heart diseases. Simplistically put, let's imagine in anybody's home, if you have somebody who is having chest pain or some cardiac discomfort, and you're living in some remote area where ECG probably cannot be reported by a doctor, let alone leave a cardiologist, if you have AI and the AI is well trained, what we'll see is this ECG can be reported, and most of the times some arrhythmias like atrial fibrillation, like very simple atrial flutter, can be picked up early from the ECG itself. And if you have an ECG which is bizarre, like an right bundle branch block or something like that, even it can help up in finding out some structural heart disease associated with the ECG. The loophole is you have to be doubly sure or confident that this ECG is picked up in the correct way. The loophole is if the ECG is picked up and it says it's an acute myocardial infarction, that means to say it's a heart attack, and the patient starts moving from that place to a different place, all of the system starts moving and it involves a lot of money. It involves a lot of logistics. Therefore, till this date, we have to assure that this AI mode is safe and is validated. And that is where a lot of work is still going on. So echocardiography, everybody is aware. We, in all our households, we have someone who has undergone an echocardiography. So echocardiography, as from a cardiologist perspective, is a procedure where we tend to measure different dimensions inside the hearts. We tend to measure the blood flow. We tend to see the structural anatomy of the heart involving the blood vessels and all the components. So if AI comes to our help, we can actually give a very automated chamber quantification, thereby ruling out the bias. What is this bias? We have the observer bias here. If I feel that the chamber is 55 millimeters, somebody or some of my colleague might feel it is 57 millimeters, depending on the cuts, depending on the respiration, depending on the ECG gating, depending on various factors, it can change. Having said that, AI in echocardiography will help us in giving a standard value which probably will not have an inter-observer variation. It can easily detect valvular heart diseases, and there are certain new things coming up like caption health, echo net dynamic. These are nothing but these are techniques where you pick up, in simple terms, fluid accumulation inside the lungs. Where is it important? This is important in patients who are likely to go into heart failure in the next 7 days or so. So you can predict when a patient comes to us for an echocardiography, he has some symptoms of shortness of breath, breathing difficulty. The patient comes to us saying, I'm having breathing difficulty for last 1 week or so. And we do certain newer techniques like caption health or so. We can pick up and avoid unnecessary hospitalization by improving the medicines given to the patient, by optimizing the medicines given to the patient. So this is going to change the scenario in the coming years, and I strongly believe that in the Western countries, these will be picked up much earlier than us because of cost issues and other logistic issues, and they will be integrated in the cardiovascular healthcare in those countries. And mostly those are documented, those are controlled by the insurance people. We do not have that amount of coverage from the insurance companies. So this is going to be expensive in the initial days. But then once we pick it up and we integrate it, rather combine it with the human force, that the doctors and the AI, this would be a great tool to prevent a lot of wealth drain from the patient's perspective, and which will be actually good in the long run. So coming to AI in cardiac CT and cardiac MR. So again, cardiac CT and cardiac MRI, these are like CT and MRI. We all know CT and MRI, but probably very few of us in the audience would be knowing about cardiac CT and cardiac MR. Cardiac CT is equivalent to doing a CT scan of the abdomen or CT scan of the pelvis, which you are aware of. Cardiac CT is a analysis, morphological analysis of the heart as to what is the thickness of the various chambers, the dimensions, the valves, all this. And MRI is the tissue characterization. So simplistically saying, if I say that there is a room wherein the measurements of the room, the length, breadth, height, thickness, number of windows, the ingress, the egress, all of these parameters will be given by a cardiac CT. But if you want to know the material of the walls, the cupboards, the inside volumetric analysis and all will be given by a MRI. So this is a common theme for all CT and MRI. And even in CT and MRI, we have a lot of data coming up. So from 2020 onwards, we have multiple papers being published in reputed journals like the European Society of Cardiology, JACC, Journal of the American College of Cardiology, Circulation. We have BMJ publications, JAMA publications. All of these publications, they are going leaps and bounds in cardiac imaging. Cardiac imaging is something which is picking up in similar pace with other imaging also. So radiology is such a discipline where if we take the image and we store it in the form of deep learning or neural networks, we are going to have a data bank in millions, and they will definitely be much better in terms of interpretation. So if I mean to say, if a radiologist or a cardiac radiologist sees a CT scan of the heart and comments that this myocardium apparently looks normal, however, there are certain areas of probable haziness suggesting some infiltrative disease, AI, on the other hand, will definitely say that this is probably this disease and not that disease because it can analyze. I'll give you a small example. In the times of COVID, lot of CT scans were taken. Those CT scans were all analyzed, and there was a pattern through which we could have told that this CT scan is likely to push the patient in a danger, and these kind of CT scans are not that dangerous. So with human learning, what we have learned is we have seen CT scans. So probably at my stage, I might have seen 5,000 CT scans, but an AI might have seen 5 million or even more. So with that amount of data, the precision comes into play, the measurement precision comes into play. The only drawback is, as we see in our practice, radiologists often will report that this has to be clinically correlated. So unless and until you have a good clinician, these values will become worthless. So what I mean to say is, if you send a patient for a cardiac CT and the cardiac CT is being reported as some rare disease and the patient is totally asymptomatic, then it is your judgment and discretion as to how to treat that patient, because this dissimilarity or disparity can create a lot of confusion. For example, if I'm working in a corporate and a patient has a diagnosis, a very rare diagnosis, been given by an AI engine, he comes to me in search of a treatment and I clinically find him to be absolutely normal, then I will have a very tough time explaining that probably this is a very, very rare disease and you are totally asymptomatic. You may not require any treatment for now or as of now, because he will be totally scared to death by reading everything about that disease in Google. So we have to always work in tandem, rather in complementary digital footprint with the AI and give a definitive diagnosis. So plaque and myocardial scar analysis, I'm not going to details, but these are the characterization of the tissues. So if we see a heart which has a lot of scar, we can always say that this patient is going to land up in a lot of arrhythmias or probably in heart failure in the long run. By seeing the plaque composition, what is a plaque? Plaque is, non-scientific terms, it is the blockage, what we say in layman terms. And in scientific terms, it is a plaque. Plaque is nothing but a mixture of fibrous tissue, lipids, that means fat, and various types of cells. So with seeing that plaque itself, an AI can comment the incidence or the probability of a heart attack in a person. So this is going to be very, very interesting in the near future, because once we subject a patient, all of us wants to know all of us wants to know the future. And it's not a sci-fi movie, but then it's not bad to know what is the probability of you or of all of us having some kind of disease or some kind of heart attack. So these kind of tests in the future will tell us, by seeing the plaque morphology, the amount of fat tissue, the amount of fibroblast, the amount of other cells, they will be able to tell us the probability of having a heart attack in the near future. So AI in coronary angiography. So let's say I am an interventional cardiology person. So I will do coronary angiography day in, day out. By this time, I have done more than 10,000 coronary angiograms and coronary angioplasties. So what till date, there is a debate that I feel this blockage is maybe 70%. Somebody else feels that it is 60%. Somebody else feels that no, it is 80%. Now, this variation from 60 to 80 may be there in certain group of patients, which we call as borderline lesions. And it would be a tough time for the cardiology people per se to come to a unanimous decision based on the angiography alone. So we have developed other techniques like the fractional flow reserve, that is FFR, we have IVERS, we have a variety of other modalities. Now, if we have AI, which can actually integrate the data and tell us in real time the lesion quantification. So a patient comes up to me, he's on the table, I have done a coronary angiography. AI is a good friend of mine. He tells me, look, doctor, we have a patient who has a 70% blockage, and but his plaque composition is not very good, his blood flow is not very good, it's not laminar. So if we see that there are certain components of non-laminar flow, certain components of high adipose tissue or high lipid core, we can actually tell the patient that, see, your lesion may appear harmless on the coronary angiogram to our naked eye, but in actual world, from the inside, this is a burning problem and can land you up in a heart attack in the near future. So this has a lot of implication because the patient sometimes will go home with a lot of apprehension that I have a borderline lesion. He can go to other cardiologists seeking for opinion. And with each and every opinion, there would be a lot of confusion. And we have seen this enough times that what should I do? Should I undergo an angioplasty? Should I be kept on medical follow-up? Should I increase the dosage of my medications? What should I do? So all of these questions can be answered by utilizing artificial intelligence in the cath lab on a real-time basis. So FFR estimation by heart flow, these are certain benchmarks, heart flow, cath walks, these are trademark registered things which can tell you on an experimental basis the actual nature of the lesion. So in simple terms, what I mean to say is not only the morphological analysis is important, but also the physiologic analysis of that thing is very, very important. So coming to AI in pathology and genomics. So we sometimes see that certain young individuals do die suddenly. We have a lot of reports that young individuals going to the gym, certain reports after swimming, certain reports after walking or morning walk. Most of the times they are involved in certain activities, probably higher than normal intensity activity, and they are actually slipping on to a phase of non-responsiveness, and they are being declared a sudden cardiac death. So there will be certain cardiomyopathies. They fall into something which is called as cardiomyopathy, and there is something called electrical disorders of the heart. So both of these cardiomyopathies and electrical disorders are genetic. They carry genetic signatures. So the commonest cardiomyopathy causing sudden cardiac death in the young is hypertrophic cardiomyopathy. And with utilizing the artificial intelligence, we can actually map the gene, we can array the genetic material of an individual by utilizing the CRISPR technologies and other technologies, CASP technologies, and then integrating those data, we can actually start a personalized therapy. So there are multiple examples. So let's say a patient comes to me at the age of 35 and we see that the LDL receptor gene is probably deficient, so it has a lot of implications. So I can actually tell him that since your this gene is deficient, you are going to have a lot of LDL cholesterol, that is bad cholesterol in your blood, and probably in your lifetime, this is going to give you a lot of trouble in the form of all adverse cardiovascular events. Similarly, in a patient who has a history of sudden cardiac death in a family, and his son is in currently young, he also has started a family with a small child, you can utilize the AI data to have a total genetic imprinting and then predict the risk of sudden cardiac death based on the genome sequencing. So as fancy as it may sound, but then these days we have genetic sequencing already available. If we have a gene bank, which is also being prepared as we speak each day everywhere, we are going to start precision medicine or personalized therapy in the next 5 years or 10 years or so. The only problem is there are certain ethical concerns involved in this kind of science, as we all know. So predictive analytics in cardiology, again, it's a very important topic because 50% of the cardiology outpatient visits are regarding some important questions like what is the chance of me having a heart failure? What is the chance of having a sudden cardiac death? What is the chance of having a myocardial infarction? Should I take statins? Statins is something which is a medicine to lower your blood cholesterol. How much should I take, and what is the percentage of my risk of all kind of events? So these kind of questions, we have a lot of engines, a lot of scoring systems in cardiology where we can put all the parameters and the scoring system guides us. I'll not say it dictates us, it guides us to take certain decisions based on multiple factors. So these kind of things are actually routine things, and we do not like spending time in doing these kind of things. The simple reason being, it's a work which needs a dedicated assistant who will write or put the data on place, then calculate the data, then discuss this. So these all things can be done by a robot utilizing the artificial intelligence. The patient can actually see and read by himself that what is the data and why is it so. And after reading, if he feels that a question needs to be asked or probably a therapeutic concern is there, he can definitely talk to a cardiologist or even a physician to clarify that doubt. It saves a lot of time in a busy OPD. Why I'm saying this, a cardiologist, a busy cardiologist or a busy physician may find a question very less important, but to the patient, it is a very important question. For example, a 40-year-old healthy man comes up with a bunch of investigations. He's totally asymptomatic. He lands up to my OPD asking, Doctor, I'm very scared. My so and so has died of a heart attack. Now I'm getting sleepless nights thinking that whether I'm going to have the same. So once I see him and once I start flipping through the pages, I may not be interested in evaluating him further or doing the risk stratification. And I will just pass him off as saying that all your reports are okay and you can visit me after 3 months or 6 months. But then if we have a scoring system, it reiterates, it gives us extra confidence to the patient as well that, okay, so my scoring system tells me, let's say my ASCVD risk score is less than 5%. That essentially means over the next 20 years, the event rates are going to be less than 5%. So it instills a lot of confidence to the patient apart from the doctor itself. This will tell him that, okay, probably if the factors are getting controlled, I'm not going to get any of the bad events in the near future. And AI-based risk scores are outperforming the traditional ones. So traditional risk factors, we tend to utilize the simplistic ones just to save time and to make it more simple. But AI-based risk scores, if we enter the data and somebody just enters the data, a lot of AI-based risk scoring systems will come up. So coming to AI in heart failure management. So heart failure management, remote monitoring and predictive alerts. So what is a predictive alert? Predictive alert means, let's say I have implanted a pacemaker, an advanced pacemaker in one of my patients, and it has a technology which can actually measure the lung impedance. So the pacemaker is implanted right beneath the skin, but it can pick up the lung impedance by utilizing certain therapy parameters, which is integrated within the pacemaker circuitry. And utilizing that, we can actually say or probably comment that the lung impedance is increasing, meaning to say the lungs are becoming wet or water is accumulating inside your lungs. The alert will be sent to the physician concerned. He will increase the injection dosage or the tablet dosage and probably will prevent an heart failure admission. And heart failure admission, as we all know, it's a very expensive thing. A single heart failure admission can drain a lot of money. So if we save one admission, we are saving a lot of money apart from the lot of logistics involved in patient care. Even a hospital bed, 1 day of hospital stay, the caregiver discomfort, the patient discomfort, everything. And subsequently, if we can measure the various parameters without touching the patient, by just keeping something over the patient's body, we can up titrate or down titrate various medications based on the AI intelligence. So this is again very, very important. This again saves a lot of time to the doctors. In the West, in Singapore and all, we have a lot of heart failure clinics. So even where I did my DM, we had a dedicated heart failure clinic. And heart failure clinic will have three, four, non-doctor people. There will be heart failure nurses, heart failure clinician, a heart failure data entry operator. All of them will see the patient. They will feed the data into the computer, and they will automatically generate what is to be done. And then finally, the patient goes to the doctor just to have an overview that okay, all of these changes have been done, and what do you think? So that saves a lot of time. So imagine in a busy OPD in a heart failure patient, if you have to see 100 patients, it's not a matter of joke. So if you pass them through an AI driven machinery, the doctor itself gets less fatigue, the entire system, the heart failure unit works well, and the patient goes home in a happy manner. So for the hospitals also, it is a better treatment effort in utilizing the AI rather than not utilizing the therapy. So AI in acute coronary syndrome, like in heart attack, we can utilize in ECG interpretation, in risk stratification using an AI. That would be very, very important. Now, this is one of the most important variables, AI in atrial fibrillation. So AI in atrial fibrillation, if somebody is not aware, I will tell you it's a kind of arrhythmia which is very common as we grow older, specifically in patients who have diabetes or hypertension or who smokes or who do have a coronary artery disease. This is one of the commonest arrhythmias to have. And believe me, atrial fibrillation is actually one of the difficult substrates to treat because it seldom goes away with treatment. It is something which is going to stay with you, and this is going to give you trouble more often than not. So we have the Apple Watch, which is US FDA approved. We also have the Samsung Watch, which is CE approved for detection of atrial fibrillation. And believe me, a lot of patients these days do come with alerts coming from the Apple Watch that you had a arrhythmic event in that time period. So atrial fibrillation is an arrhythmia which can cause stroke. It's an arrhythmia which can cause heart failure, and it may be so that atrial fibrillation may actually herald the onset of more sinister diseases. So if your smartwatch is giving you an alarm that you had an episode of atrial fibrillation, do not lose any further moment. Get in touch with a physician, get in touch with a cardiologist, and get yourself checked for more sinister things. And secondly, as cardiologists, if we are going to ablate this, what's an ablation? Ablation means if we map the geometry inside the heart, pick up the points from where the arrhythmia is arising, and then ablate utilizing a thermal energy or a cold energy. We can do both. It can predict the recurrences after the ablation also. Coming to AI in hypertension and lipidology. So personalized drug response prediction, this is one of the very, very important patterns. So if I measure, like the example I gave you, If I measure the amount of PCSK9, if I measure the amount of LDL receptors, I can measure the amount of drug levels inside the body. So some patients you'll definitely see somebody is on 20 milligrams of atorvastatin and is doing extremely well. Somebody is on 80 milligrams of atorvastatin but still has a heart attack. So if to explain this discrepancy, we can have a personalized drug response prediction. More commonly, let's say, giving an example, in all households, we must be aware of hypertension patients. So with raised blood pressure, we oftentimes get to hear some comments like this. Doctor, I am taking telmisartan 80 milligrams, 5 milligrams of amlodipine, 12.5 milligrams of hydrochlorothiazide, but still my BP is not controlled. But see, my so-and-so cousin is taking only 2.5 milligrams of amlodipine and his BP is well controlled. Doctor, what is wrong with me? So to understand these complexities of biology, we can actually have personalized drug response prediction by utilizing artificial intelligence. We can also utilize in learning the various BP patterns in artificial intelligence. AI in cath lab and PCI. What is a cath lab? Cath lab is a place where we work. It is like an OT to us. OT in layman terms is a place where all operations are done and all procedures of heart like angioplasty, pacemaker implantation, radiofrequency ablation, except open heart surgeries are all done inside a cath lab suite. That is where we do under a fluoro guidance. So there also we can have a robotic PCI. So we have robotic PCI, which has been in use for the last 10 years or so in certain areas. Even in India also we have robotic arms, which helps us in guiding a PCI. And if you integrate the AI with the robotic PCI, it can help you in further characterization. AI in electrophysiology. What is electrophysiology? Electrophysiology is the electrical circuitry in the heart, the most complex of the of I'll say all the animate series. We have the most complex heart. The simplest heart comes from the amphibians. Amphibians have the easiest circuit inside the heart, and we have the two separate circulation, the right and the left, all separated, and we have the most complicated electrical circuits running inside the heart. And simplistically saying, these are responsible for your day-to-day heartbeats. So we can utilize AI for mapping the arrhythmia circuits. So arrhythmia circuits are similar to your electrical circuits. Simplistically put, these are like you know, a wire which is going inside your heart multiple times in twists and turns. And then we tend to find out where is the fault, which wire is problematic. And like an electrician, we actually cut out the wire and fix the heart. It also predicts the ablation outcomes. So we have a joke amongst us that cardiologists are of two types basically. One is a plumber, one is an electrician. So who is a plumber? Plumber is somebody who is doing angioplasties, or in layman terms, utilization or putting of drug-eluting stents to clear your blood vessels so that you have a good flow. So we glorified plumbers. And we have somebody called electricians who take care of the electrical supply of the heart like electricians do. So electrical system of the heart is responsible for sudden cardiac death, for bradycardias, for tachycardias, and herein your cardiac implantable electronic devices like pacemaker, AICDs, cardiac resynchronization therapies, leadless pacemakers all come into play. And nicely, so all of these devices are getting integrated with the AI in the coming days. So AI in structural heart interventions. Structural heart is the valves. So we have something called the aortic. We have four valves. All of us are aware. We have two valves on the right side. We have two valves on the left side. And these days we are actually coming out of the era of open heart surgery and utilizing a small cut wherein we can change the valves also, which is called as TAVR, transcatheter aortic valve implantation. We can change all valves without cutting open the chest. So keep it simple. These days we are slowly moving away from the bypass surgeries and we're coming to less invasive options. where the patient can be discharged the next day. We can never imagine these things maybe 10 years back, where a patient is undergoing a valve change and getting discharged on the next day. But then I will not oversimplify things, but these are the things in vogue now, and we are actually going ahead with light speed in terms of evolving technologies, which will make us depend less on the cardiac surgeons. Who is a cardiac surgeon? A cardiac surgeon is somebody who actually cuts open your chest, sees your heart directly, changes the valves, puts in grafts. So cardiac surgeon was the people who used to operate and do bypass surgeries and valve replacements. And slowly and gradually, cardiac surgeons are becoming our friends in these kind of complex anatomies. So cardiac surgeons and interventional cardiology people like us, we are working in tandem to give the best possible benefits or the best possible results to patients who are at high risk. So example, 85-year-old gentlemen, we have grandfathers at our homes. Imagine one of the main heart valves, that is the aortic valve, which supplies blood to all parts of your body, getting blocked because of deposition of calcium, and he's getting severely short of breath. He's having, loss of consciousness, and he was absolutely fine even a year back or so. So these days, at the age of 85, also we can implant a transcatheter aortic valve, and the patient can be discharged the next day. It might sound very dreamy, but then if you go through the various anecdotes and the various stories available in social media and in various scientific forums, this has become the norm of the day. And day by day, we are venturing from aortic valve to mitral to tricuspid and pulmonary. This has changed the scenario of congenital heart diseases also. AI is coming up in a great way to help us in that manner. So this is what we have seen in 2024. The European Society of Cardiology, artificial intelligence transforms cardiology sooner than expected. This was a state-of-the-art review, one of the finest journals in cardiology, the ESC journal in 2024. They showed that we are going to have artificial intelligence in clinical findings, in biomarkers, imaging, portable devices, biometrics, treatment, prognosis, diagnosis, and disease phenotyping, all of them leading to personalized medicine. So we are actually heading towards a future where, as patients, we are going to have a profile where we know that at this age this is going to happen to me, or at that age that is going to happen to me, and we are going to control or try to control the probable factors which can lead to catastrophic complications. So this is a image where we can see an Apple Watch in the middle, commercially available smartwatch with an ECG sensor, CNN algorithm providing an inexpensive, I'll not say inexpensive, but then it's a good non-invasive approach for long-term AF surveillance. On the left-hand side, we have the coronary angiogram. Please don't be worried. This is a picture of the heart with the image of the coronary artery. These are your arteries. The black shadows are the contrast which is flowing through the arteries when we inject a contrast inside your heart. And this is how it looks when you do a coronary angiography. And on the right hand side, we have the cardiovascular imaging. We can have three-dimensional, four-dimensional imaging where we can regenerate the images. Imagine a complex congenital heart disease in a 2-year-old child where the heart is deformed by birth, and cardiac surgeons need to plan in precision before any surgery is performed regarding the feasibility of the surgery, regarding the complications, and regarding the logistics. All of them will be impossible if you do not have a AI generated image showing the exact chambers of the heart in 3 dimensions or even in 4 dimensions. And these are not in fantasy. These are being done day in, day out in the centers of excellence, like the centers where I have worked. These are being done and these are being implemented in congenital heart surgery. AI in remote monitoring and telecardiology. So we in telecardiology, we can have integration with the smart devices where we can send predictive alerts to prevent hospitalization. Coming to AI in cardiac rehab, personalized rehab programs where we can attach AI algorithms to put these patients into rehab modes, emotional motivation for monitoring via the AI apps, validation of the AI models. We can validate the models through external validation and data set bias and generalizability, regulatory and ethical challenges, something called as explainability and transparency of FDA and the EU frameworks. We are coming into the forum of the FDA and EU to have the changes. Data privacy and security, we have something called the HIPAA and the GDPR compliance, federated learning. The most problematic area where I was also involved in a project while I was in AIMS Rishikesh, we had something called CTFFR. So CTFFR is something where we do a, where we have the CT images and where we can integrate the FFR imaging to give us an exact picture of the coronary arteries. But then the problem arose where we had to send all of these CT images to a centralized server and which was not in India. So now the ethical questions are the disclosure of the patient details, the disclosure of the patient history. All of them are going through a third party to a different country and getting analyzed. So these are the challenges when we actually start processing the images in huge numbers. So a lot of these challenges will be solved in due course of time by taking due care, and then integration into the clinical workflow. Will definitely face barriers. We'll have a lot of questions as to how to implement AI in clinical practice, but then we should all remember that AI is a support. So we are utilizing chat gpt, we are utilizing perplexity pro, we are utilizing consensus and so on and so forth. So these are going to help us and they are not going to replace us. We cannot replace something who's building a bridge, or somebody who's treating a malaria and dengue patient with someone who just diagnoses malaria or dengue. That is not possible. Similarly, these are going to be complementary and help us in taking more critical decisions, in predicting future, in giving a more precise medicine. Cost and accessibility, reduced diagnostic cost in the general long term will be definitely helpful to integrate AI in clinical practice, avoiding the digital divide, major clinical trials and studies. There are a lot of trials from the Mayo Clinic, from the Stanford. We have something called the Google Retinal Cardiovascular Risk Model, AI-driven personalized cardiology, combining genomics, imaging, and clinical data, cardiovascular drug discovery, deep learning for the new therapeutic targets. We can actually generate the new therapeutic targets by studying the various genetic sequencing in individuals. And the future directions in cardiology will be explainable artificial intelligence, multimodal, and federated learning. So in summary, AI enhances and not replaces the cardiology people. We are going to stay, we are going to work in tandem or hand in hand with the robots and the artificial intelligence care providers. This is going to help us in the earlier detection, better outcomes, and better personalized care. I will end here and I will thank all of the people who are involved for giving me this opportunity in front of the august audience to speak uh, something about the importance of artificial intelligence in cardiology. If there are questions, I'll try to answer them as I can. Thank you so much. Thank you for your patient hearing.
Thank you, sir, for the wonderful session. Anyone having any question, please do feel free to ask, sir. If anyone is having any question, please do feel free to ask, sir. Anyone is having any question regarding how to bridge AI with engineering background with medical world and all? Anyone? Uh, so if anyone is not having any, Dr. Shomujit Ghosh, Dr. Shomujit Ghosh, please unmute. Sir, please unmute Dr. Shomujit Ghosh.
Okay.
Sir, please unmute Dr. Shomujit Ghosh. So his
Uh,
question is, how can AI assist in interpreting complex diagnostic tests such as echocardiograms to identify subtle abnormalities that might be missed?
Dr. Ghosh, sir, it's an excellent question. Now, please understand that AI will actually give you everything. Now, missing a diagnosis and the AI picking up is also very, very important. So let's say I'll give you an example. Sometimes you will find the echocardiogram ejection fractions differing by a lot. Somebody is coming up with the echo report of 50%. Somebody is saying, no, it is 30%. So AI will be very, very good in predicting those because it can calculate through various methods. Now, having said that, AI, the subtle things, whatever we are thinking as subtle abnormalities, those subtle abnormalities, even if they're picked by AI, has to be clinically correlated. Let's say if AI picks up there is a echogenic spot inside the left ventricle and it is being mentioned as a comment, I am not interested in having an echogenic spot inside the heart. So why I to give this example was, if you do a fetal echocardiography, the parents, even during my time also, if you mentioned echogenic spot noted inside the left ventricle, so the parents will be absolutely scared. What is this? What is an echogenic spot? What are the implications? And if you read Google, they will say echogenic spot can be found in 3 or 4 conditions. But most of the times it is a normal finding. Now, once you tell someone that there is an echogenic spot inside your heart, for the next 6 months, the mother will be absolutely tensed that what is going to happen to my child. So subtle abnormalities probably are not very important, specifically from the AI perspective. Another example is ECG overdiagnosis. We have a very tough time explaining to a patient that your ECG is not interpreted in a correct manner. They will come with ECGs which are mentioned as abnormal, but then we are seeing that this is not abnormal. So my point is your AI should be integrated in such a way that it gives you precision in terms of the therapy. But if you ask me subtle things, we probably do not want subtle things to be picked up by AI. In surgery, if you want, let's say while you are doing robotics, there your precision and subtlety will help you. For example, I am implanting a stent in a segment which is 32 millimeters, and while implanting, the patient takes a deep breath. The stent can come up by 1 millimeter or 2 millimeters. But if the AI guided robot is doing, he will precisely implant within that 32 millimeters. So that is where the importance of subtlety comes into play, not in diagnostics. I hope I have made myself clear.
Yes, sir. Dr. Shomodev Ghosh has thanked you for your nice and insightful explanation. There is another question from Sachin Ahankari. Can we predict the heart health with the help of AI images and reverse them?
Excellent question. So see, AI images, if you ask me, heart health, if you I was describing, a lot of patients will come to us these days young. They will ask what is the chances of me getting a heart attack. So we have a lot of algorithms, lot of questionnaires and scoring systems which AI gives you in a very clear manner that this is the evidence or this is the chance of you getting a heart attack. And I think with the coming days, this will be picked up a lot. So I also want my patient to know after doing an angiogram that if there is a 40% block and the AI tells me that this 40% block can actually progress in the long run to a 80% block, it will be definitely helpful for the patient. So these things are coming up and these things are going to become the future in no longer than 5 years or 6 years. We have some, I'll give you an example. We have something called as the LCBI, Lipid Core Burden Index. So if you have an AI integrated machine which is picking up the LCBI, they will give you a plaque analysis on the table that this patient has a 70% lipid-rich plaque, and this lipid-rich plaque is going to rupture in next 1 year by seeing the composition. And definitely these patients has to be taken in a very strict manner. This patient may be referred by a primary care physician receiving a small dose of statin. Now, when I see this kind of things, I will definitely prescribe the much higher dosage of statin. That is the importance of integrating AI in precision medicine.
Thank you, sir. So there is another question. How can AI-based monitoring system enhance the early detection and personalized management of blood pressure fluctuations in hypertensive patients at home? The question is from Shreya Ghosh Dostidar.
So thank you for the question. So first thing is, you see, AI-driven algorithms will not be able to detect hypertension early. What you can do is you can do a genome sequencing analysis, or what we call as genome-wide assay, GWAS. What we'll do is we'll pick up all the genes. We'll pick up the genes which are responsible. It's a multifactorial genetic system array, and we'll pick up all the genes which are responsible for hypertension to develop at a certain age. And with AI, this is possible that it can be predictable that we are going to have hypertension at such a young age, or probably at the age of 40 years. But for now, we do not have a predictive algorithm from AI to pick up blood pressure. What we can use AI is we can use the smartwatch by different algorithms to measure blood pressure. And the Samsung smartwatch is a CE approved smartwatch to digitally measure blood pressure, which can help you by predicting that your blood pressure is changing from a pattern which was, let's say, 120 upon 80 a couple of months back, and now it is 160 by 80. So utilizing AI, this is where a precision comes into play also. This is one of the areas where I would like to improve my precision, where AI will tell me that my blood pressure is, exactly 130 by 80 or exactly 140 by 80. And these days, with these technologies, we call as cuffless BP. There is no further requirement of a BP cuff. We can utilize something called as, you will be familiar with photoplethysmography. With photoplethysmography, we can extract information by utilizing the pulse transit time, the pulse activation time, wherein the impulses after being generated from the ECG, the watch measures it, the time delay from the starting of the ECG R wave to the watch getting the reflected wave, and then correcting for the different parameters and giving you a value. So AI is going to be more precise in predicting your blood pressure in the coming years.
Thank you, sir. The next question is from Unupal Chaudhuri. He writes, suppose a 2.5 years baby has VSD of about 2 to 2.5 AM. How can AI predict whether that can be automatically closed without surgery? If so, then how?
That's an interesting thing. See, please let me clear this. VSD is 2 to 2.5 millimeters. Your algorithms, I can tell you, your AI will not be able to tell you what is the chances of getting it closed. It has to be a personalized medicine, because taking a decision to close a VSD is entirely clinical. The doctor has to see multiple things and then decide whether to close it. If yes, how to close it, when to close it. How AI can help, I'll tell you. If AI is able to do echocardiography, it can help you the precise sizing of the VSD. And if it is a complex VSD, it will ensure the routability of the VSD. That means to say, if you have to tread a complex path, AI generated images will tell you as to how to tread that path. Because sometimes in congenital complex heart diseases, the surgeon is at a loss as to how to put a graft. Simplistically understanding, I have to go from one room to another, but there is no straight path. So if I have to go, I have to take a meandering course. Now that meandering course will be definitely uh, elucidated well by utilizing an AI technique. By naked eyes, you cannot see which AI can do. So in planning complex surgeries, AI will be definitely beneficial. But before that, whether the patient needs surgery, if yes, how, what, when, has to be answered by the clinician.
Thank you, sir. The next question is being posted by Mr. Joydeep Nath. Is there any AI-based app which can diagnose our heart health approximately?
There are no AI-based apps, but there are scoring systems easily available. You can look up something called as the Framingham Risk Calculator. We have the ASCVD, Atherosclerotic Cardiovascular Disease Risk Calculator. Talking about cardiology, we have the SCORE, the European system, SCORE, score calculator. We have the syntax calculator, then we have the Q risk 2, the Indian substrate. So a lot of scoring systems are there. If you want, you can just simplistically put your values, your height, weight, and whatever things are being asked. You can put all of those values. A scoring system will come, and you'll get to know that what is the possibility of any cardiovascular event in the next 10 years. These are easily available.
Thank you, sir. The next question is being posted by Professor Shomiran Mukherjee. Can AI-based cardio problem detection device at home, can we have that before going to a clinic? And will it be cost effective?
Excellent question, sir. So these are already in vogue. As I was mentioning, we have devices these days which are implantable, and we have implanted where it can detect the lung impedance. That is why I was talking about. And we have certain commercially available devices where let's say it's a device where you just put it over your chest for a couple of days, and it will keep on continuously measuring indirectly the fluid status of the lungs. So why lungs? Lungs, because lungs is the organ which is before the heart. So whatever blood goes to the heart actually passes through the lungs. So if there is a heart failure or there is an impending heart failure, the lungs definitely becomes wet. The lung starts accumulating water. So we have integrated devices wherein we can utilize the lung impedance and we can predict heart failure. There are devices coming from Terumo, Japan. These are approved devices. These are commercially available also, and these are cost effective also. There are devices which can be given by the vendor by 15,000 or so, if I'm not wrong. Now the question is, how user friendly is this, or how often do we prescribe? We do not often prescribe because we tend to see that patients can actually understand their own problems unless and until the patient is not taken care of or he stays alone. Most of these devices in the Western world has been developed because patients are staying alone. So Bluetooth connectivity or cloud connectivity, physician interlinking or physician notices alarms, these are all advised because most patients are staying alone. But these days, what we are coming through, we are also seeing the similar thing. Even in Kolkata, 30% of my patients, when they come to my clinic, they will say we are staying alone. Nobody stays with me. My son is in US or my daughter is in UK or something like that. So basically, we are going to those days where we need cloud monitoring and we have devices which are commercially available for it's the same development.
Thank you, sir. The next question is being posted by Mr. Shomik, whether AI is helpful for cardio-oncology.
So cardio-oncology, AI, we do not have devices, but then cardio-oncology, mostly there are medications where we tend to see the left ventricular function coming down. I'll give you a short example. A patient who is having a breast cancer, he is on or she is on certain medications which can actually depress the function of the left ventricle of the heart. So what AI can do? AI effectively can pick up in a very early stage, but routinely we do not do in clinical practice. What we do is we do something called as GLS, global longitudinal strain. By strain imaging, we can pick up. The problem is if we tend to do one echo will take a lot of time. And the GLS patterns may vary, again, inter-observer variability. So AI will be a very, very powerful tool in detecting subclinical LV dysfunctions, and that is coming up. Cardio-oncology segment is one segment which is growing rapidly because various chemotherapeutic drugs actually cause some kind of cardiac problem. It can be arrhythmia, it can be increase in blood pressure, it can be causing a clot inside the heart, it can cause LV dysfunction. A lot of things can happen. And we tend to get a lot of referrals also. And we do not have a lot of data also in this kind of aspect. So AI in cardio-oncology is going to help us a lot by predicting LV dysfunction in this group of patients.
Thank you, sir. The next question is being posted by Dr. Prasanta Puho. Can we expect one day AI agent will be installed in our body that will continuously detect the variations with more deeper insights and will ask for precautionary measure through some external devices connected with it?
So I think we already have the Apple smartwatch, which will give you a lot of notifications. So these days, patients are coming to us who will say that my Apple Watch, I was swimming and my Apple Watch gave me a alarm that my heart rate was 165. So imagine a young man who's swimming 165 heart rate, and the Apple Watch gives you a signal that this is not a normal heart rate. It's a very, very important finding. It's an extremely important finding. Even man comes to us saying that I felt dizzy at my office. He's 65 years old and his Apple Watch has given a warning. You see that it's a ventricular tachycardia at that point of time. Luckily, the patient did not have any symptoms. So probably extrapolating that, we are going to see something of this sort, maybe a chip or something like that, which can be implanted. But then a lot of ethical questions do come into play. Because once we start experimenting with our body, as we have seen in various sci-fi movies also, there will be a lot of things which will come with that. So apart from the ethical challenges, implanting a small chip probably will be helpful in the future to predict certain things. Yes, that's my thought.
Thank you, sir. Anyone, any question? Any more question? So, Mr. Abhishek Banerjee has asked, what is practical feasibility of deployment of ML-based models trained on longitudinal ECG data to capture subclinical changes to predict cardiovascular disease progression before symptoms appear?
Okay, very interesting. But then I'll tell you, if the patient is asymptomatic, if you advise a patient to do an ECG, he will not do. This is our experience. You ask a patient to get an ECG done, if he's asymptomatic, he will not do. So unless and until that's what I told you, that this has to be covered by insurance. If you're paying out of your pocket, nobody will even do an ECG which is 200 rupees. That's our experience. You tell them somebody to do an ECG, well, why will I do? That's a simple fact. But then the scientific part of it is, by ECG, the ECG is not a great tool to detect subclinical diseases. It's a very gross tool. So utilizing longitudinal data from the ECGs to detect subclinical diseases is practically not possible. Your ECG will become abnormal, signifying that there is a gross disease. Am I clear? Once your ECG has become abnormal, please understand that you are having a gross problem inside the heart. Unless and until you're having a gross problem, your ECG won't change. So if your ECG is changing from normal to becoming even slightly abnormal, you have to take good care of the heart. And as for taking ECGs randomly, if patients are willing, if the insurance companies are paying like in US, definitely we can do a lot of ECGs and start. I mean, the example is patients coming for a routine checkup, you can sometimes find a lot of VPCs, ventricular premature ectopics. You will find out a lot of arrhythmic problems. You can find out a lot of other things. So you can tell them that this ECG is not normal. You can go ahead to do some other investigations. But then making a routine ECG for routine analysis would be difficult in logistic manners.
Thank you, sir. So, anyone, any other question? So thank you, sir, for all your valuable opinions. And I am privileged enough to thank you, sir, on behalf of entire organizing team of Future Institute of Engineering and Management. And we express our heartfelt gratitude for taking your time out of your busy schedule to be with us today. So your insightful thoughts on artificial intelligence in medicine and cardiology have truly enlightened us and inspired us to bridge engineering with medical field through AI. So AI-based risk scores, predictive alerts, BP pattern analysis, personalized drug response prediction will not only be helpful for doctors, but will definitely boost patients mentally a lot. And we, from the non-medical background, we are all eagerly waiting for the transition from the bypass surgery to the less invasive options. So we are deeply appreciative of the effort you took to encourage us so meaningfully and make this session so informative. And we would like to also to thank everyone in the audience for attentive participation and enthusiasm. Once again, thank you, sir, for sharing your valuable experience, time, and we hope to have the pleasure of welcoming you again in the future. So thank you all and hope we have many such wonderful sessions ahead. So we are concluding this session. Thank you, sir,
Thank you.
and thank you all.
Thank you so
Thank
much.
you.
Thank you, everyone. Thank you.
Thank
Good
you,
night.
sir.
Thank
Thank
you.
you. Good night.